Okay,
there we go.
Thank you.
So moving us along, a quick nod to the many folks who contributed to the development of our framework. If you're new to the collective, this guides how we do our work. We're very much a systems level collaboration, looking at how do we work together better to support the many programs and initiatives in our region. And the bottom is like the system that is, well, up here is how we focus the interventions and the work we're doing here together. And we continue to grow. We're excited to say, as of yesterday, on our roster, 216 organizations strong, and our networking site, we had 65 folks join there in the past quarter. LinkedIn is growing a bit faster, which of course makes sense. We're excited about the growth there for both of those online presence. And encourage you as you go, as you hear the updates, to connect. We've got that link there in the middle if you want to join any of our work groups as well. And then there's our social media sites. The links will be put in the chat. And we are excited, in addition to growing membership, we're growing our team here at UT Health in our backbone organization role for the collective. We have Maggie Green, who has joined as program manager, who will be taking the lead on our work in the community health worker efforts, kicking that off. And then Andrea Harther, who is joining as our communications specialist and will really help develop strategies for telling the story of our work together. And moving us along, I wanted to also share that we're looking ahead to later this year, our fourth quarterly meeting. This is our second. Our fourth quarterly meeting this year will be held November 2nd, and we're planning to do it in person. Watch for more details on this, but we really want to build this out with a poster session allowing you all to profile the work that your organizations are doing to promote health and health equity across our region. So more to come on that, but I wanted to put that on folks' radar. And when we're talking about getting the word out, lots of exciting things. I'm actually going to be presenting our work in a national SDOH collaborative effort later this afternoon. And then we have, across our work groups, had a number of abstracts accepted for conferences coming up. So the Healthier Texas Summit will be presenting on the work that's happening with the community health workers, as well as in the health and housing. Thank you to those teams who took the lead on those pieces. And then in Austin, a little bit later in October, we will be the closing keynote speaker for TSOFI, and then moving to the national conference with the American Public Health Association in November. We will again be presenting on the community health worker efforts. And so if you're attending those, do let us know. We'd love to see you at those events. And with that, I'm going to pass it to Shrila to talk a bit more about what's happening here as we look to build out the strategies and foundation for this work as backbone organization.
Thanks, Heidi. Good morning, everybody, and welcome. Please feel free to again introduce yourself in the chat. I'm Shrila Sharma. I'm co-lead of the Health Equity Collective alongside Heidi, and also director of our Center for Health Equity at the School of Public Health at UT Health Houston. And as some of you, maybe all of you may know, the School of Public Health is one of the 6 schools that are part of the UT Health Science Center here in Texas. So the center was established in fall of 2022. So we're coming up on a year. But mainly with the intent of providing scaffolding and infrastructure to support all of the efforts around health equity that many of us are doing, many of you are doing, many of our faculty have already been engaged in. the work of the Health Equity Collective and to catalyze and accelerate new efforts that might be needed in our region. Next slide. So I know this is quite a bit on a page. I'm not going to read it all out, but just want to share our vision of healthy people across flourishing communities. But I also want to call out, I'll talk a little bit more about our framework here that's in the middle. That's sort of like a 3-layer cake is the analogy we like to use, which is the framework that has infrastructure, intelligence, and engagement in it. And I'll talk about that in a minute, but also want to call out our values and the expertise that we bring to the table, specifically around social and structural determinants of health. And we have our website at the very bottom where we're still building it out. There's a lot that we are adding to the website. So if you want to learn more or you want to engage with the center activities, do reach out to us as well. Next slide. So I did want to spend a couple of minutes just sharing about our framework, because I think this is particularly relevant to the work of the Health Equity Collective. So when you think about a 3-layer cake, the best bite is when you go across the 3 layers. And as we think about the work of health equity, the layer of infrastructure really becomes critical. I know I'm preaching to the choir here, but when we think about the layer of infrastructure, we're really thinking about, are we asking the right questions? Do we have the right data systems to inform those questions? Are we convening the stakeholders and creating the appropriate table to inform and move these efforts in the way that they need to be? And a lot of that requires capacity building. And so that's been the primary function of the Health Equity Collective, which is really the layer of infrastructure for that is supported as part of the center. And then if you have the right infrastructure and capacity, then you can have you can generate appropriate insights. And so that's our layer of intelligence, which is at a broad level, converting these data elements into insights to drive action. We have a social measurement and evaluation core where we are building out a lot of the data capacity, the evaluation capacity to inform that's generated from the layer of infrastructure to really inform the very top layer, which is the layer of engagement. And that's primarily associated.
Okay.
Oh, hi. I guess, and then the top layer of engagement is the programs and services. So if you have the appropriate infrastructure, data insights, that can then anchor your programs and services in the best way possible. And so we're doing a lot of work around food as medicine interventions at this point. So developing the capacity in our region to implement and evaluate food as medicine, so food prescription programs. So this is just at a high level, the framework that we're operating under with the Health Equity Collective as our layer of infrastructure. Next slide. So I just want to end on this particular note, which is what is the role of UT Health and the center in regards to the Health Equity Collective. I think it's important to state that while UT Health has the privilege of being the backbone organization for the Health Equity Collective, UT Health does not own the Health Equity Collective. It is a collective impact effort, which means that the decision making is purely built on what happens in the work groups, and the work groups are the ones that, and the task forces are the ones that drive the efforts to fruition. So it's all of you who are participating in the work groups. It's definitely a collaborative effort. However, UT Health does play an important role as a backbone organization to facilitate collaboration to bring in funding, which is critical to push the work, and to also UT Health, our faculty have a lot of talent and that they bring to the table. And so we are looking to leverage that talent to build out some of the capacity related to research and evaluation for the Health Equity Collective. You'll hear a lot about these current priorities, but there's three main ones that we'll be discussing and sharing back with you today. One is building out the capacity for closed loop referral in our region, so that health systems and social service agencies can do a bi-directional closed loop referral. And so we are squarely into that demonstration project, which we'll talk about, but that is one of the key efforts facilitated by the Health Equity Collective. There's the community health workers strengthening the CHW ecosystem in our region by focusing on workforce and capacity development for the CHWs. So that's another effort that we are working on as well. I think another role that UT Health plays is, since we're in the School of Public Health and part of five other entities, one of the roles we play is making sure that we are bringing these priorities back to other institutions and engaging our faculty in this work as well. Next slide. Well, I just want to say thank you, but mainly share our contact information and our website. This deck will be shared back with you. So feel free to reach out to us. We've been chatting with a lot of y'all, happy to continue that conversation. All right, so with that, I think we're going to jump into sort of looking under the hood on a lot of what we've been doing with the closed loop referral demonstration project. It's been successfully launched. I think last quarter meeting, we did give an update on the governance side of things, which will continue today, but we have successfully launched the demonstration project, and we'll share over the next 5 minutes some of the details. Next slide. All right, so I think we wanted to spend just 30 seconds level setting on why the need for this particular demonstration project. We acknowledging that we are a region of high need with large disparities, specifically large needs around social determinants of health. But we are also a region where many of our organizations have invested in addressing these issues through technology or increasing the human capacity of care coordination. So, we've stepped up. I know UT Health does a lot of care coordination. All our organizations seeing the need have just stepped up, whether it's screening, whether it's referral, all of the above. What we realized in many of the conversations that we've had since actually February of 2020, that we need to leverage these existing investments. And so through this demonstration project, we are here to create a patient-centered bi-directional closed loop referral capacity between healthcare and social services. But the key here is we want to leverage these existing investments. And we know that success really depends on co-creating the plan for implementing this through partnership, meeting the systems where they are. I mean, if you ask organizations to invest in one more platform, that's just not going to happen. And then most importantly, meeting our patients and clients where they need us at, when they need us to be there. So these are sort of the main ingredients that are sort of our North Star in how we are approaching this work. Next slide. And so I want to call your attention from this has been in the works. Many, if not all of you, have been involved in these conversations going left to right on the timeline. Just want to call out that we had our first convening of the executive leadership, the third row, in February 2020. which is when about 40 leaders across our region came together to really inform, well, is there a need to do this? And if so, and then what is at a high level the vision that we want to do this, use to do this. And so we've been following that blueprint. We've been building it out. We built out a resource directory exchange led by PCIC over this past year or so. And then last year, over a year, since 2021, we contracted with Aja. And Aja really has extensive expertise in our region in building out collaborative governance for this type of work when it comes to data sharing. And so we built out our charter, and Aja, they'll share a little bit more today, has been building out the governance for this closed loop referral demonstration project. There's a lot, as y'all can imagine, there's a lot of data sharing that happens in this space, and organizations have to come together to think about all of the pieces within and around it. We definitely have sustainability and also evaluation as a major priority of this closed loop referral. Are we being effective? Are we being more efficient? Being the two main questions. So there's a lot of work that we are engaging in at this time. Next slide. Many thanks to all of the organizations that are participating in this demonstration project with many different roles. Some are, our technology experts, then of course, healthcare community organizations, and UT Health is serving as the backbone organization and fiscal agent. Next slide. I know this is a lot, but this is at a high level, the blueprint of this effort. On the left-hand side, we have the healthcare organizations that are participating in the demonstration project. We are leveraging, I think going back to leveraging existing investments. We have a very robust health information exchange in our region, Greater Houston Health Connect, with a master patient index of about 15 million. And we wanted to leverage this asset. And so we are leveraging the Greater Houston, and that's the box you see in the middle. And then we are working with a technology vendor, they're called Ready Computing, and they have a channels product that integrates seamlessly into the Greater Houston Health Connect system. They're built on the same InterSystems solution. And and then on the right-hand side, that will carry this channels product into the social service agencies to build out bidirectional closed loop referral capacity. And we have been very intentional in identifying existing robust efforts for care coordination to be included. So Combined Arms, as many of you know, is a very successful care coordination platform in our region, and also United Way integrated client journey as well. So we wanted to test and try out different ways to, and what is the way that's preferred by organization, and then also informed by the clients and patients themselves. And at the bottom, you see the governance, data sharing, contracts, all of the operational work that is being facilitated by Aja and UT Health. The last thing I'll point out here is that there is a PCIC, we will leverage the investment that we made last year in the resource directory exchange that brings together the resource directories across PCIC, Wellnity, Combined Arms, and United Way that will be available as well as part of this effort. Next slide. These are our main questions that we're looking to answer, and you'll see on the next slide where we are at right now. But we have two very simple questions. Are we being more efficient and are we being more effective? But a big part of this is going to be that we want to evaluate if these investments are having an impact on both process outcomes, right? Is it improving the processes and efficiencies within our organizations that are participating? And then is it, also, our social needs outcomes, so food insecurity. And over time, if we build out this backbone for evaluation, then we can look at even impact on health outcomes. So we're building those pieces out. And the second piece we're building out is what is the sustainability of this work, and how do we scale it once proven to be successful? What does that scale up look like? So those are that's another piece that we're working on. And with that, I want to share, next slide, where we're at. So starting again from the bottom, we have an MOU with Greater Houston Health Connect. We're very excited to enter the contracting phase with them and Ready Computing to build out the technology capacity. Again, 100% of the healthcare organizations that are in the demonstration project already pay to play in the HIE. So that's why we want to leverage that asset. We are building out the governance that's initiated, very, very much in progress, and initiated the contracting work, as well as data sharing processes. Aja is really facilitating a lot of that. And then once we have these 4 pieces shored up, we will squarely and quickly move into the testing phase, which we're aiming for Q4 of this year to enter that phase. And then sustainability is really cross-cutting. It's not something we'll wait on till the end. We're starting those conversations now as we speak. And next slide. Want to also share, I'm not going to read this out, but just how is closed loop referral being defined? How are we defining it? And using the best practices around closed loop referral as well. So this is a resource that we've been using to move our work forward. Next slide. And with that, I want to hand it over to David Goodman, who is leading the collaborative governance effort for this work. David.
Thanks, Srila. I will say I don't think I've ever described the governance framework in terms of cake before, but I think the 3-layer cake is a great example of how collaborative governance should work, because if you think about the different layers, there's a lot of different ingredients, a lot of different systems, a lot of different organizations that are responsible for providing the ingredients for making that 3-layer cake. As Srila mentioned, there's a lot of data, there's a lot of constraints and restrictions, both institutionally, but also statutorily with the organizations that we're working with on restrictions on how you use or share that data. So the collaborative governance is working with the mission of the HEC in terms of meeting organizations where they are. They have their own data, they have their own systems. We don't want to mandate or require or impose any requirements for participating in this. So we do this process collaboratively, which means that we sit down with each organization and we find out how they can participate and what are the data, technical, and governance specifications that they need to share their data, to connect their systems, and to extract value for their own organizations. Because if they don't like the cake themselves and don't eat it, they're not going to have a lot of incentive to maintain this over time. So the framework that we're using for the closed loop referral demonstration project and for HEC more broadly is 3 components. There's a collaboration agreement, which is really, if you think about it, like a master services agreement. How do we work together? Who's in the kitchen at one time? Who's the sous chef? Who, combines the ingredients? All of these are fairly static on how we work together. The authorized project is sort of like an SOW. So that's the specifications for the data or the specific recipe that we are working together on that day. And I say that because you all are working on multiple initiatives and projects in the region, whether it's through United Way's integrated client journey or other work that might be bilateral partnerships with your organizations. And we want to be able to leverage that. We don't want to add redundancies or add additional burden on your staff. So these projects are designed to connect, and we use an SOW to create the specifications for how we work together. And then how do we sustain this? Srila mentioned that sustainability is such a key issue here, but we also want to manage and monitor this so that we're adhering to the practices or the agreements that we've made together. So we form a governing body, and that can look very differently. It could be an existing body, it could be a working group within another body, but the idea is that we all have skin in the game, and we want to manage and monitor and sustain this over time. And how can we leverage what we're doing around the closed loop referral and build on that to do other things? I noticed that there's someone here from United Way of Greater Austin that's doing the model community. It may be in the future that the work that we're doing in Houston can connect to that work. And we use this agreement, both the collaboration agreement and a specific use case, to connect with them so that we don't have to reinvent the wheel and we can seamlessly work together. Next slide, please. And why are we doing this? And I mentioned a little bit this already, because this is something that we want to be sustainable. We want to build sustainable regional capacities and trust. You'll notice in the 3-layer cake, none of those layers are going to stay there or work together if the trust isn't there. So we want to be both solve our collective goals and our common pain points, but we also want to serve and provide value for the individual organizations that are participating. We have to do this collectively because, but for us working together, some of these issues or challenges we can't address on our own. So this is the collaborative governance helps us do that and protects your organization, but also make sure that we do it in a way that doesn't add burden or create redundancies in the region. We also want to level the playing field. The reality is that there are some organizations that have expertise, they've got great resources, but there's a lot of organizations that are doing really great work in this region that may not have an IT staff, or they may not have a researcher that knows how to integrate this data or share it with other organizations. So we want to create a system that allows us to level the playing field and become equitable so all organizations can participate, contribute, and extract value from it. And we want to, as I mentioned also, we want to build the closed loop referral to not only solve the immediate issue of increasing referrals, doing the closed loop, but we want to use that data for other purposes in the future as well. Whether it's doing the evaluation that Srila had mentioned so that we can improve reimbursements, we can secure additional funding. The CBOs that we're working with can kind of show additional value and get additional funding and grants for their work. So how could we build this and then extract more value out of the work that we're doing? Next slide, please. And then we had mentioned a little bit about how this process works. So governance is easy when you can impose or mandate it upon the organizations you work with, but that isn't ideal. And it doesn't always allow us to incorporate the needs, the data, technical, and governance needs of each individual organization. So we sit down with each of you, we understand what data do you collect and how do you use that data in your referral system, so that when we put a common plan together, it incorporates the specific data, the specific systems that you work with, and the specific governance that you need in order to share and use it for either making a referral, receiving a referral, things like that. We'll then develop this that will help kind of inform the data sharing agreement or the data use agreement that's needed for your organization to actually share the data or connect the systems. And then we hand that over to our technical partners, Greater Houston Health Connect and the Ready Computing folks, because they will not configure anything that you all have not approved for participating in this process. So we help the technical partners understand the data technical and governance constraints about how to connect systems, how to the workflow of the data, and making sure that that's done based on your specifications. And then finally, we use all that information, then goes into the collaboration agreement, and we have the governing body that can continue to manage and monitor that to ensure that everything is done as approved, that nothing is being done that you all have not approved or accepted as a part of this project. Next slide, please. Yeah, and I think we use this slide, as I mentioned, nothing happens in the technology that we have not identified and you have not approved for your organization through governance. Again, this is different from traditional data sharing, but it's also something that's really critical for your ongoing incentives for participating and extracting value. Next slide. Yeah,
Thank you. Thanks, David. That was fantastic. And I really see how this collaborative governance approach is setting us up for not just the work we are doing in the demonstration project, but also scaling it into the future. So thank you, David and Aja and all of your team members. And we wanted to take a minute to introduce someone who's not new to our region, but new in his role with Greater Houston Health Connect. Next slide. So I'm going to turn it over to Junaid Hussain, who is the new Acting Chief Executive Officer at Greater Houston Health Connect, who is one of our partners in this demonstration project. Junaid?
Thank you, Srila. Can everybody hear me?
Yes.
Oh,
Welcome.
excellent. Good morning, everyone. It's an absolute pleasure to be joining you this morning for the quarterly meeting of the Health Equity Collective. And as Srila mentioned, I am Junaid Hussain, the acting CEO of Greater Houston Health Connect, the health information exchange for the region. Just a little bit about myself. I'm a fiercely passionate and proud Texan and a longtime Houstonian resident, along with my beautiful wife and 3 kids. We've lived here in Houston going on, call it 15 years, and this is my 7th year with Greater Houston Health Connect. And as I'm very proud to say, this has been the most satisfying job in my long healthcare career, because I know the good work that we do here at Health Connect has a lasting impact on the community that I absolutely love. Here at Greater Houston Health Connect, we coordinate care for the community by integrating the many different electronic health record systems of our provider participants. And as all of you may know very well, the different electronic health record systems really don't speak to each other very well. Epic doesn't talk to Cerner, Cerner doesn't talk to Athena, Athena doesn't talk to ECW, but through my company and my company's platform technology, we can facilitate the sharing and exchange of healthcare information across the community so that clinicians have access to patient medical information available to them right at the point of care. You know, we work with small, medium, and large healthcare organizations, ambulatory practices, hospitals, health systems, imaging centers, clinical diagnostic labs, anywhere that care is delivered. We work with those organizations to ensure that patient medical information moves along with the patient so that we can give that 360-degree overview of the patient experience. And we do all the good work that we do in this community as a 501c3. We're a not-for-profit entity, just like many of your organizations. We're here to improve the health of the communities we're engaged in. And speaking of those communities, our catchment area consists of over 75 Texas counties representing South, East, and Northeast Texas. We have well over 16 million patients in our clinical data repository. So as you can see, we have considerable reach in the communities we're engaged in. Greater Houston Health Connect is absolutely delighted to participate with the UT Health Equity Collective on this very important community initiative. The closed loop referral demonstration project leverages the health information exchange, data assets, and technology solutions. But I want to be clear here. Fundamentally, this project is about community building. It's about nurturing relationships with healthcare providers and building bridges with community-based organizations to ensure that the citizens of this great community are really receiving the full person care that they need, care that transcends just their basic healthcare needs and is more broadly focused on addressing social and economic disparities and inequities. So just a few weeks ago, Health Connect signed a memorandum of understanding with our friends at UT Health, we're formally kicking off this initiative, and now the hard work begins, right? As we work with the pilot organizations and our community-based partners and our technology vendors to really implement this demonstration project. So I look forward to working with many of you on this important initiative. Thanks so much to Srila and Heidi for advancing this work. I know they've worked on this for many, many years, and Health Connect is just humbled to participate in this initiative with all of you. So thanks so much, everyone.
Thanks so much, Junaid. And let's go to the next slide. And we're very excited again to work with all of the partners here. Just want to acknowledge the two halves that are working together on the left and right-hand side, the provider agencies and the CBOs in this demonstration project. And we are looking forward to continuing this work to address whole person care. We are definitely approaching this from how is this going to work for both the agency as well as the community that we serve. Next slide. And we also wanted to share that the timing of this work is couldn't be more relevant right now. There's a publication that has just come out from the Episcopal Health Foundation that talks about adopting community resource and referral platform considerations. But we also want to call out the new CMS requirements, also HEDIS measures, JCAHO. Everybody is now going to require health systems to engage in screening and response and report on those. And so a lot is being put into place from the healthcare side of things, which means we need, again, going back to that layer of infrastructure, we need to strengthen our regional capacity. All of us have been engaged in this work for years. I was doing food insecurity work when it wasn't popular. People were like, how do you define food insecurity? But we need the capacity to do this this work of care coordination and do it right, so that the programs and services that meet the needs can survive and thrive and such. So we wanted to share these new developments that are coming down the pipeline for the whole country. And with that, I think that's next slide. I will pass it back to you, Heidi, to talk about our CHW. And if you have any questions, I know this was a lot. If y'all have any questions, and I saw a couple of questions in chat, we'll answer them as they come through. But yes, please, David as well, feel free to answer some of those questions that are coming in the chat as you feel comfortable, and Junaid as well. Thank you.
Yeah, thank you all. Really excited about the progress there. And shifting to another robust effort with the community health workers, we're really privileged to thank you, Tanweer, for that $5,000 donation. We're really privileged to be a part of the work that's happening across the community health worker workforce in our region, and to be a part of looking to develop, how do we strengthen this really critical workforce in our region. And so thanks to the Houston Health Department for their investment in the Health Equity Collective. I'm not going to read all of the details here on the slide, but really looking at some of our key targeted priorities in building out strong, cohesive CHW network. Really, what does that look like? What does it look like to improve equity across this workforce? And we've been doing a lot of learning in this space, and in looking at how does that connect to the existing trainings and the trainings that may be needed. What are the principles of structural, procedural, and distributional equity? And what we're learning all along is that our opportunity is to improve equity through and with the organizations that are already working in this space. And then And then also looking at how do we connect the conversations and create a more cohesive communication hub and strategy. There's a lot of good information that kind of ebbs and flows through this community. So this is the journey that we have been on. Many of you have been with us. We've had conversations and have been looking at what might be a shared opportunity in this space now since really the end of 2021. And here we are in July at this point. And so you can see our priorities. We had a fantastic visioning session back in June. We'll talk a little bit about the highlights coming out of that. And that visioning session was really built on quite a lot of listening in a way. A lot of the precedent what we've done in all the different areas across the Health Equity Collective's work is start with listening, bringing stakeholders together and listen to what's happening and what are the opportunities, what are the gaps. So you can see there were a lot of assessments, interviews of and data gathering. And we're honing in on these priorities. So more to come, jumping in. So one of those information and listening activities was around key informant interviews. And you can see the three themes that came out of those is really there's a need for stronger infrastructure for this workforce. Community health workers around the world, when they're set up for success, have improved health outcomes and health equity dramatically. There was a great story back in 2021 in the New Yorker of community health workers and how they were used in the country of Costa Rica to dramatically increase life expectancy over about 20 years. And then community health workers are trusted liaisons between communities, within communities, and between organizations. How do we support them in that important work? And then community health workers are, as they're looking to do this work in our region, in our country, facing quite a number of structural barriers that keep them from being as impactful as they could be. And a lot of that is how their roles are structured within organizations, and some of the expectations of them that are not maximizing their role in the community. So how do we create that space? So those were the themes there. And then one of the other activities that was really valuable is we brought together a focus group size of community health workers and worked with a graphic artist, Peter Durand, and did a journey map. I'll show that to you in just a moment, of what is the community health workers' lived experiences and what do they see as the key opportunities and key challenges. So you see the highlights here on the slide, and then I am going to show you our journey map. Which of course is very small with all the content, but you really see the themes that come out, and we'll share these slides with everybody after the meeting with the recording. But here at the top were the themes and really kind of the flow of community health worker experience. One of the things that we acknowledged is that this is never a linear experience for individuals. And then here at the bottom is really kind of the ecosystem that community health workers are working in, and that support and influencers. Around here are what was framed as the roses, buds, and thorns, the challenges and opportunities around positioning community health workers for success. So there's a lot here to digest. We could spend a whole hour on it, which we don't have the time. But I do encourage you to take a look at this, particularly if you're working in the space of care coordination and or with community health workers. So the themes that came out of that are also consistent with what came out of our landscape scan survey. Many thanks to those of you who completed that. We had about 80% of the community health worker employers in our region complete this survey. And so some of those staff, those gaps around training and support, about half of the organizations are providing ongoing training for their community health workers. Some of the needs that emerged through the pandemic were around mental health support and technology-based training. I will also say some of our response to working in heat, that's something that's just come up this week. So that we're hearing back of really being mindful of what's happening in our communities real time. That was a good reminder of that. In Texas, Texas actually leads in the certification of community health workers. This is really important. The certification and recertification process for our community health workers. The reason that that's important is that the certification is actually connected to quite a bit of the strategies for reimbursement that are in those discussions, and some of the bills actually that just recently passed in our state are tied to that, the certified CHWs. And then less than half of the organizations are supporting their community health worker staff members in memberships of the associations and professional associations. And I think across different roles, we know how important professional associations are for being as effective as possible in our role. Not a lot happening in advocacy. And definitely opportunities for improving community engagement opportunities. And moving along, one of our key challenges that has come up is the lack of a consistent definition within the role. Also issues around pay parity, job insecurity, a lot, like 71% of those surveyed, our community health workers are primarily funded through grants, which means they are inherently short-term positions, or they're not stable, they're not guaranteed over time. And we know what that can do. And when we think about our own roles, if you have those questions always hanging over your head. There's also limited growth opportunities, as far as it's not clear what is a career path and what are those opportunities. So that's actually a key thing that we're working on right now. And a high level of stress or burnout, and also varied commitment towards equity. Although looking at the framing on this slide, I would actually reframe it as pretty impressive that almost 2/3 of the organizations did say that they were likely to engage in equity to advance or to advance equity efforts, excuse me. So I would frame that one as being a step in the right direction. Speaking of steps in the right direction, we had a team through the Texas Research to Policy Institute collaborative effort tracking the bills related to community health workers through this most recent legislative session, and are excited that we had 2 key bills passed. I know that Jordan Everett with our SDOH policy work group is going to speak next. But just highlighting, these are some really great steps forward, or positioned to be, as far as the more sustainable funding for community health workers in their role. So HB 1575 is poised to provide reimbursement for care coordination for pregnant women under Medicaid and certain other benefit programs. So there's a lot of development of how that's going to work underway currently at the state. And then HB 113 is expanding the definition of community health workers care coordination beyond administrative practices to medical practices, which opens up additional resources to support their work. Moving us along with that, we'll dive more into our work groups and start with our policy work group. So I'll pass it to you, Jordan.
Thank you, Heidi. Yeah, I was just putting in the chat that stay tuned on HB 1575 on Mighty Networks, because that one, our CHW experts in the membership are saying it could take HHSC about a year to implement. So there will be some opportunity for public comment on that one. But yeah, my name's Jordan Pacelli Everett. I'm with the Prevention Institute and also the SDOH policy work group. A little bit about our work group is there. We build policy collaborations, raise awareness about evidence-based policy opportunities, link people together to support each other on our legislative priorities, and educate members about current legislation. Of course, today we're going to talk about the session briefly. But thank you to everyone in our policy work group. We have a large work group, maybe like 70 people, and it depends on the month of how many folks are participating, but we're very open. Like if you're interested in a policy topic and that's what we're focusing on that month, please do join us and share your expertise. But we thank everybody so much for their collaboration and advocacy throughout the 88th session. There are some big wins that are related to health equity because of advocates' very tireless work over the last years and sessions. Some things were like, oh, we were working on that 10 sessions ago, 8 sessions ago, right? So things move slow in Texas. And of course, there were some disappointing losses and some not movement on things as well. Heidi just mentioned our partnership with the Texas Research to Policy collaboration. And they were continuously working on tracking bills that were important to the folks in HAC and in our work group. So thank you to the Texas RPC team. I'll speed through this one, but this is just a really brief since January. We kind of were like, okay, what's everybody looking at? We started scanning everybody's legislative priorities and agendas. February, we focused on food security policy with some of our experts within the membership. March, we focused on, same with experts in our membership, in our group, on maternal health policy. April, mental health policy. May was like the last week of session we met, and we're like, okay, who do people need to talk to? So it really is a good space for that. June, that was when all those vetoes were happening. Folks were a little on edge because we met earlier in June, before June 18th, when everything needed to be signed by the governor. And then July, we just met and are already starting to, we're starting to kind of process the legislative session and talk about interim discussion, like I just mentioned with HB 1575. Okay, probably don't have time to, we can't do a guess on this one, but here are, one is the 1280 number is the number of bills passed this legislative session. 77, yes, is the number of bills vetoed by Governor Abbott this legislative session, which was a historic high. It's a lot of bills that were vetoed. 1375 are the number that were sent to the governor. And then 8,530, another historic number, was the number of bills filed. That 1357 number was a 16% passage rate. Go to the next one. Okay, this will be the speediest legislative wrap-up you ever did see. Food security, a couple of great bills passed. The vehicle asset test, that's a great step forward in terms of SNAP eligibility being related to how much somebody's car costs. Also passed and signed was 1743 that allow people exiting the criminal justice system to apply for SNAP benefits prior to their release, so they can have those benefits when they return to their community, which is great. Unfortunately, a lot of our membership was working on HB 2983, and at the last minute, up into the last second working on that one for food RX programs. But this will definitely be something that comes back next session that did not pass. I think most people on this call know about HB 12, and that is a win in terms of Medicaid extension. Still not, we're one of just a couple of states that still have not expanded Medicaid, but improved outcomes definitely expected for people who have given birth, their babies, for women in Texas, extending that Medicaid coverage from 12 months to the 2 months that we previously had. And then there's a couple of other great maternal health and postpartum care bills that are there, including eliminating sales tax for menstrual products, diapers, and other maternity items. The number of representatives on the Maternal Mortality and Morbidity Committee, and basically being able to donate feminine hygiene products to places like shelters. Heidi just briefly talked about HB 1575 and HB 113, but essentially 1575 authorizes Medicaid to provide case management service for non-medical needs, with the goal of improving health outcomes for pregnant women and their children. And then HB 113 essentially moves the community health worker as employee from being reimbursed under an administrative expense to a quality improvement cost, and that one's effective immediately. Let me think. Okay, so in terms of the mental health workforce, I encourage you to go listen to NBHP. Just had a great conversation with a few representatives this week, and they talked about the mental health, and Sydney Carter with that org did a great overview of the mental health workforce. Also, Hog Foundation just had a really good legislative wrap up where they go into detail about these bills, but basically there was some great movement forward on reimbursement and strengthening, improving the mental health workforce in Texas. I think we all probably know about SB 14, which bans gender affirming care for trans minors. And then a bill that was really unfortunate that didn't pass that a lot of our members worked on was also HB 1879, which essentially would have allowed billing for mental health providers in Medicaid. There's a lot going on here too. Unfortunately, on this session, started off talking a lot about school behavioral health in terms of that there were going to be a lot of bills passed, and that did not happen in terms of access for students. HB 3 passed, which was a sweeping school safety bill instead. That has a lot more provisions around hardening schools and requiring armed officers in schools and things like that. Only a few provisions in there on access to mental health services for students. Childcare, it's cut off, but essentially it's like we were all saying those 2.3 billion knew that wasn't going to happen, but there was actually $0 in the budget for childcare services. And SB 17, we have yet to fully delve into how that could impact our work, right? Prohibiting public universities from having DEI offices, programs, trainings, or positions, as well as some bills that regulate school materials about gender, sexuality, and race. Important to note. Yes, thank you, Shrila. And then housing. And we're missing a lot here. We have more on transportation and environmental justice and the like, but housing, there were some tenant protection bills that made it further along than we anticipated, but ultimately did not pass. There was this great bill, HB 299, for the creation of voluntary accreditation for recovery housing that did pass. And then I'm sure you all know about 2127, the Death Star bill, that impacts this housing ordinance like eviction prevention, and the construction worker, there's a lot of implications with labor in that bill. But overall, yeah, so we have it on housing, but it has an impact in a lot of our work. And then that's very high level overview, but here's our contact information, and please feel free to join us at the next meeting on August 14th.
Thank you so much, Jordan. Really appreciate all you're doing to promote policy in our region, policy change. Moving us to community voice, I'm going to pass it to William Lyons and Sean Haley.
Good morning. Good morning. I think I'm kicking off for us today. Thank you very much. We can go ahead and slide to the next space. It's good to see everybody this morning. You can go to the next one, Heidi, actually. What we're going to do is just do a very quick highlight of some of the things that have been happening. The last quarterly meeting, you had the opportunity to hear about kind of some of the closing out work with Dash ABCD. How about that for alphabet soup? So data across sectors of health, asset-based community development efforts that were have been ongoing, and really tying back to all the earlier conversation. Really the heart and soul of the community voice work group in and of itself is to make sure that community voices are lifted and to help inform the work of the Health Equity Collective. And so there have been focus groups that were completed to lift up voices of folks in varying neighborhoods. In particular, this focus was on 3rd Ward and East End, kind of piloting out and getting voices so that we can hear what do people really feel like they need to be better informed? How can they be best informed? How do they gain information? So that would help inform the work of the Health Equity Collective directly. And so we did have the opportunity to do focus groups and push through on surveys in East End and 3rd Ward. What's interesting and great is that this work is going to be extending, and we're now, as noted here, strategizing of moving into complete communities areas of Alief and Fort Bend to gather even more community voice via the same survey process to help inform the work. And a report is being developed. Thank you for moving forward. No, you're good. That was perfect timing.
Okay, good.
You got me. You know me. It's like Jedi mind. So what I want to highlight, I'm going to move from Dash ABCD to what would have looked even crazier, but we did write out Houston Health Department. Otherwise, it was said HEC, HHD, CHW, just to beat out Dash ABCD, of course. But this is a grant that is really critical and focused on particularly around work elevating and supporting the advocacy capacities of community health workers. And the first bullet really highlights the organizations that are heavily engaged in really making this happen. So between my organization, Center for Civic and Public Policy Improvement, UT Health, Baker Ripley, and Texas Southern University, there has been a great push to really learn, number one, from CHWs, you know, how they define advocacy, understand advocacy, and what they need to be able to be better advocates for themselves, the communities, and individuals they serve. And so this slide essentially articulates or attempts to articulate that we have had some great one-on-one conversations with leaders, people who actually have associations or programs that develop CHWs or support CHWs to gain input. And we also have had focus group interactions with CHWs. That information has been obtained, has been analyzed, and is now being pushed across for the design to really inform, should I say, the design of modules to support development and training of CHWs. We're super excited about that. It's in the works. By the next quarterly meeting, we should be able to have, a much better, more focused report on this. And so we're excited about that. And then what we're also being able to do, and we can go to the next slide, is we are focusing on some of you guys may be more familiar than others with this. The Matrix of Community Engagement Strategies is I'll say, a resource that we're using in the collective to help us better understand, one, and help ultimately to support members of the collective in understanding how to really engage at the highest levels with the communities we're hoping to serve and or work with. And so what's depicted here, you see the ladder of engagement across the top in green. And then to the left, the axis that is in blue, you see the goals of engagement. And so there's some examples of kind of things that would happen if you were trying to engage, for example, at the first goal and looking over at the level of involved, this may be something you would do. So what's cool, and we can go to the next slide, is what we're trying to do now is, I'm sorry, we can back up. I went too far. What we're doing now, go back one more, Heidi, sorry about that, is we are engaging with members of the Health Equity Collective to conduct focus groups in order to better inform the high level strategies. Surveys have been completed right about a year ago through the Community Voice Work Group to kind of hear from people, hey, where would you like to be able to better engage? How do you know how to engage? What would you like to know more about? And so that collaborate and co-lead, if you think of this as a taxonomy, looking from inform to co-lead, the areas of collaborate and co-lead have posed, I would say, the greatest difficulties, I guess, where people are trying to figure out how do we really do that? And what are some examples? And then also in terms of the goals, really level 5 there, build community capacity down in the bottom left-hand corner to lead change, also pose some more of the complications where people are saying, we'd really like to know how. Well, there are a lot of members of the Health Equity Collective that do an excellent job of engaging community at the highest of levels. Any one of these levels, any space on this matrix is great, right? There's no good or bad. But for the most part, people don't have as much knowledge as to how to move to those, what I'm calling higher ends, collaborate, co-lead, build community capacity to lead change. So what we're doing is hosting a series of focus groups with members of the Health Equity Collective. We are actually next week going to be hosting several of those sessions. We do still have space, and I think I was rushing along. There's a prior slide, actually, the one prior, yeah. Gosh, I thought we had added that. I'm sorry, I guess we didn't add that update to this presentation. But what we'll do is Isla Prieto, who should be on the call right now, we will add to the chat if your organization does extend and engage communities at those higher levels of collaboration and co-leading to resolve issues, solve problems and concerns, we'd love to engage you in the process. And so what I'll be sure to do, and I apologize, I thought we had updated the slide, but we will just put into the chat if you're interested. We actually have a couple of times and dates. Let me see if I can just look to the side that are upcoming, and we'll put how you can engage on behalf of your organization in the upcoming focus groups. And then the next slide, I think, is William was planning to just kind of take us into next steps. And then we're super excited after we get past this, to introduce Jen Hadaya, who will be sharing kind of along the lines of what I was just talking about, an example of how an organization within the Health Equity Collective is reaching those higher ends of the continuum in order to really solve problems with the communities they serve. William, are you on, sir?
Yes, I'm here.
Excellent.
So what we've been actually doing as well is with our work group members reviewing the engagement matrix, and we've received feedback respectfully about some of the misalignment. So when we think about the highest level of co-leading, is that just offering trainings to the community or to the community, or is that something else? And so one of the things we're working on is looking at some of the other frameworks regarding community voice work or community engagement. So we're hoping we can solicit experts to kind of speak to the network about their use of some of these frameworks in their work today. So we have human-centered design, trauma-informed community building, community engagement studio, and really looking at those deeply and seeing if they provide additional examples or activities that relate to the engagement matrix to fill it out fully so people can feel comfortable that they're working towards something that's achievable. The other thing that we are working on is working on spotlights within our work group meetings. So there's so much great work going on in our region. And so having people who are doing great community engagement, utilizing community voice in their decision-making, to kind of invite them and speak to our work group so we can learn from their expertise, maybe even shadow them if there was an opportunity presented and come from there. And we have one person presenting today. Later on, Jen Hadaya from Air Alliance will be speaking about her work with Air Alliance. And just to kind of echo what Sean was speaking on earlier, we really are looking forward to some of those DASH learnings and really looking how to share that amongst our ecosystem. And that's a perfect segue.
All right. Hi, everyone. I'm Jen Hadaya with Air Alliance Houston. I know that we're running short on time, so I am going to skip all the way to the 7th slide, Heidi, if you're steering. The early slides are simply why we talk about air quality as an upstream determinant of health. I think probably everybody on this call knows that. We are in the middle of a heat emergency that is directly related to air quality. The heat emergency we're in is a climate change byproduct. Climate change is caused by the same things that pollute our air, and what heats the climate causes health issues upstream. Not only is there a heat emergency, but there's also an ozone emergency, and ozone is one of the major polluters here in the Houston area. Here's where we're going to be. See, got through 7 slides. So that's what we do here at Air Alliance Houston. And one of the ways we do that is through elevating community voice. And so these are some values that we maintain in all aspects of our work. That every environmental decision is an opportunity for community voice. Those who have been harmed by air pollution deserve to influence the decisions made about air pollution. And one of the maps that we scrolled through very quickly shows you the Houston arrow as it relates to environmental exposures, and environmental exposure is not created equal in the Houston area, and that has to do where people live and where polluting sources have been placed, and that tends to affect people who are Black, brown, and lower income. And so it's truly a upstream health equity determinant and one that has downstream inequitable outcomes. So the lack of transparency as a third value to our work in the current environmental decision-making process is an intentional policy decision meant to disenfranchise communities and make it easier for polluters to pollute. There's my soapbox for the day. So as an organization, with these values in mind, we took on an effort beginning very intentionally this calendar year to infuse community voice throughout all of our campaign work using the ladder of community engagement. So if you want to pop to the next slide, This is an overview of all of, sorry, that didn't work out so well, but this is an overview of all of our current campaigns. And you'll see that we instituted for this year, Community Voice as its own intentional campaign that works to infuse all of our other campaign efforts. I would say that embedded in Community Voice infrastructure is also language access infrastructure, work that we've been doing over this year to be multilingual. So the work we do to reach and engage and activate communities are now conducted in English, Spanish, and Vietnamese. We've also, as an infrastructure approach around Community Voice, instituted what we call a Healing Justice Initiative that elevates and prioritizes wellness of the whole person, and bringing that to community members who are literally living, breathing, no pun intended, this work as an act of survival and need support as people in their wellness to prevent burnout, and acknowledge that this work is very, very hard. And the people who live with it every day tend to be the ones working on it every day. So this is what we've done. We use the ladder of engagement. Next slide. Very similar to the matrix that William and Sean presented, with a little bit of a twist. We've used the IAP2 version, which uses the phrase empower at the end rather than co-lead. Same thing. So one of the things we did to institute Community Voice this year, next slide, is every single one of our campaign leads sat down and filled out this form. This is an example of one person's form, where we had a reading club, a lunch and learn, and peer-led conversations about the ladder of engagement, and then sat down and filled out this form for every one of our campaigns, so that everyone on the team is thinking intentionally about how to integrate Community Voice across the spectrum into each of their campaign efforts. And so, yes, of course, just as William and Sean have said, getting further on that co-leading model, you'll see it's an inverse proportion. There's lots of things we do to inform, and then they slowly start to dwindle when we get further across the spectrum. But we are moving forward on that, and you'll see that in my final slide. So I wanted to pick out a couple of examples of work we're doing at each place of engagement here. So there are macro examples, and then within each campaign, they are also moving across this ladder of engagement themselves. So next slide is an example of our Inform, one of our signature Inform efforts, and this is called Airmail. This is an automated system that scrubs permit applications and automatically notifies residents of their opportunity to speak up and out about a polluter in their neighborhood, whether that be a refinery or an asphalt plant, as the picture shows. So on the left is what Airmail looks like in its mapping form. On the right is the postcard we're able to automatically send out to people within a radius of the permitted facility. And we have been surveying people at permit meetings, and about 65% of them say that they learned about this opportunity to speak up because of receiving this postcard in the mail. So this is a initiative we've been running for about a year. We've sent out 60,000 postcards at this point to make people aware that they have an opportunity, they have the right to speak up and out against polluters. So that's a good example of what we're doing to inform. Next slide. Another example of what we're doing to consult. I don't think CBPR is new to anyone on this call, and that is our philosophical approach to research through mixed methods. We produce about 3 original research products every year that are used to understand the landscape and to solicit feedback from impacted residents about what our platforms and positioning should be on key issues. We did that for the legislative session as well. We built a legislative agenda with community input on priorities. We just released in June a report about carbon capture technology, and did that by asking community members that will be affected by this technology what they think are decarbonization strategies, and we are now using that to inform our platform going forward. Next slide. So an example of involve, so taking it one step further, where we are working to understand, but then also including residents in guiding next steps, is our Environmental Justice Leadership Lab. This is a hub for all the T's, technical assistance, training, and tools that we use to activate community members to be advocates for their health and the health of their communities. Our staff of the lab are embedded in focus communities. We from the beginning, prioritize lived experience in our hiring. And so the vast majority of our staff live in an environmental justice community and are deeply embedded in the work there. And then we engage with community members to inform the design and lead of these activities. So here is where we are on the continuum, starting to flip that role a little bit, where we are not always leading, but we are empowering impacted residents to lead their community work. And an example on the left is a staff person on the left and a community leader on the right in East Aldine, who co-planned and co-led a prep session on a concrete batch plant, block walking event. And on the right is another great example, co-led by multiple community members and organizations to raise awareness and identify solutions to the Project 11 ship channel expansion, which is going to be placing contaminated soil dredge spoils in Pleasantville once again. And we had 150 people come out for that town hall meeting. So this is an example of how we're starting to shift into co-led opportunities for community voice by community residents who are part of our work and that we are engaging with and nurturing on a regular basis. Next slide. Collaborate. All right, this is a fantastic signature initiative. This is our community air monitoring program. So this is a true partnership with community members who become the leads of their own work, and they enter into a citizen science initiative with us. They host air monitors. They're the two air monitors were used there on the left. There's a picture of our camp manager helping a community member install an air monitor on their fence. So they own, they monitor, they access this information. So this is truly their monitor, and they then can view and use their data on a day-to-day basis through an online dashboard. But then we also compile and bring back data quarterly to each of our focus communities. And you'll see a picture on the right. That's actually me leading a conversation with community members here in your north side to develop community action plans, which they have identified. They might be policy changes. They might be true community actions. They might be permit oppositions. They might be getting more air monitors out in the community. And then we co-implement those plans with them. So this is another step on that agenda. It is informing, co-leading, but then also helping and allowing community members to own the actions and own the projects themselves, and then tell to us what and how we can support their work. Very last one, and this is the one at the end of the spectrum, which we all know is very challenging. It is coming soon. So we have plans in this current fiscal year for us, which just started in July, to set up a series of community advisory boards that will guide us on overarching agency priorities and our new strategic plan. We will have a community advisory board. We will have a scientific advisory board, which we hope to serve as a citizen-based IRB for all the research that we're doing. And both are intended to be a pipeline to board of director service with us, so that our board is also reflecting people who are directly impacted by environmental harms and lived experience with environmental harms. And that's it. I'll just end with my last slide that says, if you are super excited about the work we do, there's lots of ways to get involved and follow us. We promise we don't send out a lot of information on a regular basis, but you too can be informed about community actions. And we do send out action alerts. If you want to raise your voice about Ozone Action Days, we have ways for you to do that, and you can follow and subscribe on our newsletter. So I appreciate the opportunity and look forward to hearing more.
Thank you so much, Jen, for a fantastic overview and example of powerful community voice engagement in action. Really, really appreciate the important work y'all are doing. And moving us along to our next work group, Dr. Williams, representing our mental health and substance use work group. You have the floor.
Yes, thank you. Good morning, everyone. I'm co-chair of the Mental Health Substance Use Work Group with Suzanne Jarvis, who's not able to make it with us today. But we're excited to kind of talk about some of our activities. I know I have a number of slides. I'll quickly go over them. I promise that I won't be too long on them. So the first thing is I want to talk about a little bit about our journey. If you think about stigma reduction and the importance associated with the work we're doing, just consider we're doing a lot of systemic work with closed loop referral. But there's a human element involving providers. There's always been this historic challenge of power and within the relationship, within professionals and in the helping field and those seeking help. And part of that is that there's always been this focus on pathology and diagnosis, and we really it's so important to kind of hear about the lived experiences of people trying to seek care. And so what we identified is what are some of the challenges that's going to be a barrier for us to really utilize that closed loop referral process that we're trying to develop with technology and so forth. And it's going to be sort of the inherent challenges of a stigma that the provider may have. And so what we looked at is how can we reduce that stigma? And so there's a whole methodology that we looked at that kind of starts, if you kind of look at the bottom of it, looking at literature associated with stigma reduction. Some of the work that the community health workers with the community voice and journey mapping is kind of the approach that we're kind of mirroring, but it's going to be people with lived experiences that will be part of those focus groups. Is going to help inform providers what are some of the challenges associated with stigma. So we're looking at how we're going to move forward with that is sort of this evaluation process, and we have an IRB process associated with that when we gather the data from the focus groups for the lived experiences. And then we want to be able to tell that story of a person that's trying to navigate into care, and what are some of the challenges and barriers for people to actually not only get to care, but also be able to flourish in those settings. Next. So, what is stigma? And so when you think about stigma, it has a big impact in how a person will even seek care. And it's one of the biggest barriers if you look at a person seeking care, how they look at even the system that they're going into. When you look at some of the challenges, even with different groups of people, people of color, and some of their historic challenges in seeking care, from everything from different past studies, it creates real challenges for people to seek care. And so when you look at this particular needs, folks with mental health are real challenged in terms of accessing care. 1 in 5 experience a mental health illness. If you look at 60% of adults with mental illness receive no mental health services from the previous year. We have a whole correctional challenge with folks actually going into correctional settings. And oftentimes it's related to untreated mental health conditions. We have real challenges with our youth and everything from suicide and also accessing care. And then we have real challenges in terms of the cost of care. When we look at the impact of stigma, there is the individual, if they aren't comfortable with the provider because of perceived stigma, there's going to be a delay in them wanting to seek treatment. And oftentimes we've seen data associated with the cost of care where folks are actually going into emergency rooms to actually look at some of the co-occurring challenges where they may have a health concern, but oftentimes it's something related to depression or some other kind of diagnosis where they're presenting. Next slide. And so if you look at Texas, there's some real challenges. This comes from NAMI. In February 2021, 43% of adults in Texas reported symptom of anxiety or depression. If you look at even some data associated with the pandemic, these numbers were even a lot higher, and folks were kind of socially isolated to even access care. Some of our systems of care actually moved toward telehealth services to try to reach clients, but even that became a challenge because not everybody has access to Wi-Fi. And so this is a real challenge where we have a lot of folks really needing care. And how do they access care? And if stigma is one of the barriers for people accessing care, then it's sort of this trajectory where folks get sicker They'll end up going to the emergency room for depression or suicidal ideations. Next slide. We can go to the next one also. And so when you think about some of these stigmas associated with mental health and substance use, folks are even accessing, when you think about drug addiction is viewed more negatively than mental illness. And so we've had challenges of folks even coming into care. We have a co-occurring really alcohol use challenge, but they won't let us know because of all the stigma associated with drug use. We know a lot of that is perpetrated even in multimedia systems and so forth in terms of how people view people that need care. And so people are less likely to want to seek care. And so if their early experiences are associated with the stigma and even the provider having stigma, then when they do access care, they won't stay in care because even some of the biggest challenges we've seen with our clients when we've done surveys is even the waiting room experience. So if you consider a person that's experiencing psychosis and they're sitting in a waiting room, you have a front desk person that has to know what is kind of going on with that individual to be able to provide care. Next slide. And so there's been some processes that we've looked at in terms of navigating the mental health system. This is a kind of a journey map that was done that involved a number of providers that kind of came together. We're really looking at kind of a model very similar to this, and also the community health worker journey mapping. Our idea is to look at all these barriers and challenges that folks are having related to stigma, and then using that to inform the provider. And so if the provider is informed with this new information about the challenges of people accessing care or even staying in care, then maybe they'll change their approach and how they are able to engage clients with lived experiences. Next. Okay, that's it.
Thank you so much, Dr. Williams. I'll call Wes, Alicia, and Melissa to talk about the communications work underway.
Hello, everyone. My name is Wes Gibson. I'm one of the co-chairs of the communications work group. Next slide, please. So welcome to the newcomers, especially in today's call. So one thing that we've been doing for the past 3 years is called a monthly virtual networking session. And what we do is we invite either guest speakers or speakers to talk on all the work topics we're doing in this space. It's normally the third Thursday of each month. And then afterwards, we post our resources on our internal communications platform, Mighty Networks. You can become a member by scanning that QR code or going to the link. Also, if you're not following us, be sure to do so on LinkedIn. But yes, one thing we wanted to do is while we're on the chat, normally as a communications work group, we'll discuss topics and pick them, but we want to just gauge where people are with them or get people's feedback or suggestions they might have for topics. So if you could just fill out the survey. I think, Andrea, you put that link in the chat, but yeah, feel free to fill that out. We'd love to have your impact. If there's a topic you're interested in or a comment you have on the way we work it, please let us know. Next slide. So just to give you a preview, we do have August and September's topics and speakers solidified. The ones from the October to December tentative. But yeah, just to give you an idea. And just one thing also I'll add is keep in mind, these are very broad topics that you might see food security or mental health, but these topics we don't just do once. There's so many different areas we could cover, or if you have suggestions for speakers, please let us know. Next slide. All right, and then that's what Mighty Networks looks like. So feel free to go there. Again, we'll also post other things there, and I'll pass it along to the food security work group.
Thank you, Wes. And we'll welcome.
Hey, good morning.
Go ahead, Hope.
Yeah, good morning, everyone. Hope Galvan with Harris Health System. We can go to the next slide, Heidi. I'm going to hand it over to my team, but I just want to give everybody a background on the past couple of years. The the food security work group has been, working on developing a learning series that resulted from a study that was done. And I want to hand it over to Maria, who is our manager in care integration, who will report out on our session 1 as it relates to our focus, which was stigma in food security. Maria?
Hi, everyone. Thank you, Hope. Yeah, so the Food Security Work Group did our first learning series session last month, June 29th. And we had the wonderful speaker, Elia Moreno. And I saw many of you in person and virtually at the event. So in the chat, if you want to just comment like what you loved about it or areas, but we had 106 participants registered for the event. The event was hybrid with the Great Leads. The Houston Food Bank was able to get someone to virtually film it while having it in person. So it allowed for that duality. And now our work group is working on our next learning session. It's going to focus on organizational capacity to address food insecurity, and we're hoping for it to be in October 23. Our work group is meeting tomorrow. So if you're interested in joining our work group and have ideas on our next session, please feel free to reach out to me. I'll put my email in the chat. And I can send you the invite, or you can send me some ideas. But our goal again is to focus on to these sessions throughout, which Hope mentioned was part of the study that came out on what our action items would be in our food security work group. So thank you. And next slide, Heidi. So this is to answer your question, McCain, this is the first food security work group. Thank you, Dr. Sharma. Some other things that have come out from the food security work group is some recent food prescription program evaluation publications. And so we have links here and QR codes that lead to those publications. Next slide. And some exciting podcasts on food security, specifically in stigma, have recently also been published. And so if you're interested, and I'm going to actually copy the links to the podcast and put them in the chat right now. If you're interested in any of listening to any of those podcasts on achieving health equity with SNAP, the challenges in accessible food pantries to drive better health equity, and the co-ops of economic development in health, please go to the podcast. They're super interesting to listen to. And as mentioned, next slide. We are a growing work group, and if you're interested in the work of food security and want to support us in making that happen, or help lend a hand in our next planning of our next session in October, please feel free to join our work group by pressing the link here, or I'm going to put my email in the chat. You can email me and I will add you to the work group. Thank you, everybody.
Thank you so much, Hope and Maria. I really appreciate it. And I will pass it now to Dan Potter to talk about the work that's happening in health and housing.
Perfect. Awesome. Thank you, Heidi. And so, yes, here to update you all on the health and housing work that we are doing. This is that combination of efforts between the Health Equity Collective and the Houston Housing Collaborative, as well as the Kinder Institute. And so just to update folks, there are two projects right now that we currently have in motion. One of them is the Eviction Prevention Project, and the other one is the Screening Tool for Housing Safety and Quality here in the Houston area. The first one is a little bit paused as we continue to delve into what this could look like and who might be the various different entities to have involved in this work, but the second one is underway. So for that second one, just as a reminder to folks, the next slide. Next slide. The screening tool for the housing safety and quality work. This is looking to try to get a better idea about what does housing quality look like here in Houston. This is based off of both the sort of current issue around affordable housing that we have, but really an acknowledgement as well that even amongst the housing that is still affordable, we just really don't have a very good idea about what type of quality those units, those housing units are. And so this project is unfolding in 3 stages. We are currently in stage 1, which is connecting with community organizations. in order to develop what we mean by housing quality. And so part 2 will involve 8,000 to 13,000 surveys being collected from Houstonians. We will be doing representative samples of each of the complete communities. The reason for that is that each of the complete communities, when they did their community action plan, stood up quality housing as one of the concerns and action items for that community. And so this will be providing data specifically for those entities and about those entities. And then third phase of this is, of course, taking what we learn through that data collection process and getting it into the community to be able to start driving action and hopefully bringing about some change. So in terms of what we have done for step 1, next slide. This engaging with community organizations and stakeholders, what we want to do in this process is, while there are plenty of metrics that are out there and plenty of instruments that have been developed elsewhere and by various entities to measure housing quality, we want to make sure that we're looking at those and recognizing what makes sense here for the Houston area. And so that is what we are in the process of doing. Next slide. In that effort. And next slide. In that effort to create a definition of housing quality, a meeting was held back on June 27th at the Kinder Institute here at Rice University, where we reviewed checklists and instruments that have been used elsewhere and other places, include New Orleans. Other checklists are such as the checklist provided by the by HUD, and looked through them to understand, what did we like about them? What were some of the key components that made sense? What were some things that maybe we didn't see on those checklists that might be more relevant to Houston? And also really grappling with the question of some of those checklists are developed in a way that really do require an expertise, whereas what we're trying to do is develop something that you, me, and the next person would be able to provide feedback on. And so wanting to make sure that we're developing something that is accessible. And so to that end, we are in the process of drafting an instrument, which we are hoping to share out with this full work group, the Health and Housing Work Group, in early August, with the goal of us having a second meeting where we will be sitting down with that drafted instrument to refine it, hopefully finalize it, and then have that definition set and ready to go so that we can begin getting in the field, hopefully later this year. Next slide. And again, just to sort of reiterate that third phase, while we are excited to get into the field and collect this unprecedented information about housing quality here in Houston, it is not information for information's sake. And in fact, we are very excited to be able to start connecting with organizations that are part of the Health and Housing Work Group to understand how we can begin connecting these data to action, to calls for action, to advocacy work. And so that'll be one of those phases that gets activated as well, especially once we know what type of information we will be collecting. It'll give folks a better idea of next steps as they think about how they want to act with those data. Any other slides for me? Nope, perfect, awesome.
Thank you,
Heidi.
Dan. Appreciate it. We'll let you take that question in the chat. And then happy to be able to share with you all some of a new development with Healthy People 2030. And without further ado, because I know we're short on time, I will call Jean Ayers to the floor to talk about this new development with Healthy People 2030.
Thank you so much for the invitation. It's been energizing for me to be part of this meeting today, because so much of what you've been discussing is how you build and strengthen civic health and civic health and infrastructure through the Health Equity Collective and all the work you're doing, all the way into the advocacy in civic participation and voting space. As I saw some questions come up in the chat. I am Jean Ayers, the Executive Director for Healthy Democracy, Healthy People. We are a national coalition of public health organizations and allies in the civic engagement space. And our overall aim is actually to, we're nonpartisan, but our overall aim is to strengthen our collective capacity to realize health and racial equity by advancing an inclusive, democracy, a representative democracy, representative decision-making spaces that promote civic and voter participation. And one of the initiatives that we have been focused on for the last couple of years is to get the Health and Human Services, next slide, please, to, actually, you can go 2 slides, forward, is to get Health and Human Services to prioritize voting as a metric and an objective within Healthy People 2030. Are you able to move my slides? Can people see the next slide?
Yeah, we're looking at the slide. I think there might be a lag on your end, Jean.
There we go. This is good. This is good. This is good. So basically, Healthy People 2030. Many of you probably know this. It sets the national health objectives. They are organized with leading health indicators, and there's a leading health indicator around social determinants of health that has a number of core objectives within it, and then objectives. It helps. It basically helps drive action and funding through the public health system and across the federal agencies, so that we have a coordinated effort to improve health at the national, state, and local level. It paves the way for health authorities to establish similar objectives in state health plans and local health planning processes, and the health planning processes that nonprofit hospitals and other groups do. So that's the sort of value of it. If you go forward, I'll just quickly, this is really just going to serve as an announcement for you. Here's some quotes from the director of the Office of Disease Prevention and Health Promotion. We've learned that belonging and civic muscle can significantly impact an individual and a community's resilience and capacity to thrive. We were able to provide a lot of research and data to demonstrate the importance of inclusive representation and health outcomes that helped inform the decision of this. So we put together the Health and Democracy Index that basically looks at 12 health indicators and the ease or difficulty of voting nationally. Next slide. And you can just see that there's a pattern that is quite apparent. So some of this research, and there's a star for Texas, on where it is. And it's basically mapped out on better health to worse health, easier to vote to harder to vote. And so there is a pathway that connects back to this new objective to increase voting ease and participation. Next slide. So the new objective is basically increase the proportion of the voting age citizens who vote. And that's just it. They're just using baseline data from 2018, and the goal or the objective is that we move in the desired direction. And next slide. So basically, in summary, it's clear that voting offers a chance for people to contribute to the decisions that can affect their communities and directly or indirectly impact their health and well-being. And it gives people a sense of purpose and social connectivity. And so all the strategies that we can incorporate into our points of contact in our work help us move that measurement toward an improved health equity overall. We have a couple of webinars the National Academy of Science and Engineering and Medicine are hosting with us in August during Civic Health Month that you can find out more about how you can use this at the as well as the county health rankings and roadmaps model and framework has also incorporated civic and voter participation into their 2023 priority areas. So you can learn more about that, and Heidi says she'll send that announcement out with the notes after the meeting. Thank you, and I can answer any questions.
Thank you so much, Jean. Appreciate this update. for Healthy People 2030. Exciting work. And now we've got a few minutes left for community announcements. And I know we had a few folks send some in ahead of time. So Ariana with Episcopal Health Foundation, are you with us?
Hi, yes, I am here.
Do you want to just do a quick update on this ask?
Yes, I'll speak really quickly. So hi everyone, I'm Ariana. I'm the community engagement intern at Episcopal Health Foundation, and I'm also a master's student at UT Health School of Public Health in the healthcare management program. This announcement is basically just asking those in the Health Equity Collective that are part of alliance, a coalition, or organizational partnership to join EHF's registry. We're basically publishing a new online resource, updating our registry and our mapping tool that's showing where different groups are located across our 80 county service area. So basically, this is just a basic resource and opportunity for exposure. And I'll put in the chat the two links. The first is just an overview of the initiative that this is under, and the second one is a survey link where people can add their groups on. And there's also a little bit more information that I posted on the Mighty Networks platform.
Thank you so much, Ariana. This is exciting. For those of you who have been members for some time, we did a survey of our membership similar to this about 2 years ago and have over 50 member coalitions. So excited to contribute to this broader mapping. It's important to know who's doing what work so we don't reinvent the wheel. And now I'll call up Tanya and maybe Chris to talk a bit more about this affordability connectivity program in our region.
Good morning. Thank you so much for having me. My name is Tanya McConey Rivera, and I'm with AT&T, and I handle government relations for the region. And I just wanted to come on and talk about the Affordable Connectivity Program, which was started by the FCC December 31st, 2022. And so as many of you have seen with your clients and just in general, during the pandemic, there was a tremendous need to have access to Wi-Fi. And so this is a benefit program. Of course, there are different qualifications. Individuals have to be have an income at or below 200% of the federal poverty guidelines, participate in SNAP, Medicaid, or federal public housing, and other things, but they have to go online first and qualify. And so it's been a challenge for us and a lot of the other providers, because there are a lot of folks that qualify for this assistance, and they would get up to $30 a month. And each internet service provider has their own pricing and things like that, but it could potentially be free high-speed internet for these individuals in their household. So we wanted to share this. And so if there are upcoming community events, we're participating in back to school events to share this information, feel free to reach out to me. I also have my colleague, I believe she might be on, Dorcas, that leads our fiber. I don't know if there's anything else that I missed. I know you guys are tight on time, but if you want to unmute yourself, then and chime in.
Good morning, guys. Yes, I do support Tanya in that aspect, and she pretty much hit all the bases. We would like to send out some information if you guys like. We could pinpoint on all of it. The biggest thing is that it's not just income based. We do have some for sure shoe-ins on that. So if we do have any students and for sure free lunch programs, those two anomalies are automatic shoe-ins to get that connectivity program discount, and that's a big anomaly for a lot of the people that are in the community that don't know that they have that option available to them. So we just want to make sure that we're getting that information out to the community so they can start to skill you off in the right direction. So I know we're short on time, as we said before, so I can get that information over to Tanya and she can spread that out to all the different parties that are on the call, and just excited to get that information out. So thank you for having us.
Really appreciate it, Dorcas and Tanya. In addition to this link directly, is this something that folks can ask the provider organizations like y'all are at AT&T, and I know we had friends from T-Mobile also in on this. Can they ask their providers directly?
Yes, they can. And just the nuance is just depending on the provider, there are some special anomalies. I know with AT&T, we do have specific offerings that are available to the AT&T customers. And then if, like I said, they're in the free school lunch program, and if they're a part of being a student, so like you guys have UT Health students that are doing, you know, vocational work, and they're working in a part of being a residency, they automatically get that discount. So if they wanted to, you know, go into a store and work with any of our representatives, they can walk them through that, so they're not alone in that process. I know a lot of people go online and they feel overwhelmed on working on, you know, reading those verbiages and things like that. So we do have people that are already versed in the program that they can help them walk through it, so they're not alone in the process. And if you have any questions about it, Tanya can put my information out in the chat, and you guys can reach out to me directly. My email is open at any time, and I can give you guys some direct verbiage as well as some links and some information about AT&T as a whole, so how we can help you guys.
Yeah, thank you so much.
That was my question. Yeah.
The question on whether or not someone has to be on free or reduced, according to the FCC website, it's benefits that are free or the reduced lunch program. But again, they still have to fill out the application, and that can be cumbersome for folks that maybe don't even know how to use a computer. And so we will be able to walk them through that. But then there are other nonprofit organizations like CompuDot and some others that we can share that are helping people to actually fill out this form, because that is a challenge. And then we do also offer classes to kind of show people how to navigate the internet, how to turn on a computer, because a lot of times we don't think about that, but there are folks that may have a phone, but this application is not something that would be user friendly to fill out on your phone.
Right.
Is there a phone number that y'all can share as well?
Yes, ma'am.
Okay, great. Thank you.
Yeah, because we'll go ahead and share this also out with the Community Health Worker Network that has some representatives here, but I think this would be a great resource for community health workers across communities. So thank you all very much. I know just about out of time.
Sorry, I was going to say one thing. This is Chris with T-Mobile. My mic wasn't working, but I think just in general, making a plug for, as y'all are out, you know, with digital equity. I know all of the providers, and you know, AT&T, T-Mobile. I don't know if Verizon is here, but we all sort of, I'd say, work together in this in a way. So just keep that top of mind. I know Heidi has everyone's information, but you know, one of the biggest issues, like with this program, is people might qualify for it and not even know it exists.
Yeah, appreciate it, Chris. Thank you so much. All right, y'all. Fantastic updates. Keep up the good work. We're at time. Look forward to seeing you in the next conversations, in the next meetings. Appreciate all that everybody's doing to promote health equity across our region.
Yes, thank you all. Mark,
thank you for
November
having us.
2nd. Bye.
Take good care.
Thank you. Bye.